uh, introduce you into few pediatric surgical topics. We'll start with two common topics and try to get maximum use of his time. Unless you ask questions, unless you clarify your doubts, just by listening to something, I don't think you all will gain a lot. You all will gain few things, but you can gain more by asking questions and interacting with him and get maximum out of him. And he also has agreed to take few students while they are doing their final surgical appointments. They will get the chance to meet him. So try to get the maximum use of this opportunity. Sanjay, I think we'll start slowly.
Yeah. Okay. Thanks. Thank you. Thank you, Ron. Yeah. So what we thought we'll discuss today are, the common presentation, one of the commonest presentations to a pediatric surgical clinic. That's a mother or the parent complaining of noticing a groin lump. So that's one of the commonest presentations to a pediatric surgical clinic. And then there will be one of the commonest urological anomalies in children would be empty scrotum. And then if we have time, we'll go on to scrotal pain and painful swelling of the scrotum. And so we'll start off with the groin lumps. And they would be, majority of them will be inguinal hernias and hydrocele. Of course, sometimes they might come with an inguinal lymph node also, that, because now these referrals will be mainly, they will not be presenting themselves to our clinics. So the lymph nodes will be treated by the general pediatrician. So that's why, although groin lymph nodes is a common thing in children, we do not see them in our clinics because they are, being mostly seen in general pediatric clinics than a pediatric surgical clinic. But so inguinal hernia and hydrocele are both due to the persistence of the PPVs, persistent processus vaginalis. So the etiology is due to the persistence of the processus vaginalis. And so what determines whether it becomes a inguinal hernia or hydrocele is entirely due to the size, the physical size or the diameter of the PPV. So if the deep inguinal ring, the persistent processus vaginalis, the opening at the deep inguinal ring, if it is big enough to allow abdominal contents, the bowel, omentum, or ovary in the female, then it becomes a hernia. But if it only allows fluid to get into the processus vaginalis, then it will be a hydrocele. Okay, one of the, there are several types. I hope you know about from your applied anatomy. There are different types. So this is the normal. So can you see my arrow on your screen as well?
Yeah, can see.
Yeah. Okay. So this is the regressed persistent processus vaginalis. So that's the normal thing. So the distal part will remain patent like your tunica vaginalis. And so here we see, so this is quite a narrow neck at the deep ring. So that allows only peritoneal fluid to go through. And so thereby you have so this is the cyst of the cord. And then you have the normal tunica vaginalis, which has that usual amount of fluids in it. So here you have a vaginal hydrocele. So there is patent processus vaginalis, but it is very narrow, only allows fluid. And so this is collecting in the tunica vaginalis only. So it's called a vaginal hydrocele, like you see mostly in adults. So that's the one. So why this fluid does not go back is because there is like a little flap where this the arrangement of these processus vaginalis is a little angulated at some part, usually at this junction, so that it allows fluid only to go this way. And fluid from the tunica will not go back readily. A little bit of it will leak back also, but most of the fluid comes this way. So then you end up with a vaginal hydrocele. And then you have the if the neck is big, the deep inguinal ring is large enough to allow bowel contents also to come through, then it will become an inguinal hernia. Okay, so and majority of children's hernias are what you call bubonosis. So, the hernia sac ends somewhere there, but especially in infants and neonates, it can be inguinoscrotal hernia also. So it will come, bowel loops will come right down, like in an older patient, inguinoscrotal hernia also. And so this is another one. Now here, that one-way valve mechanism is not developed, in the sense that it's not there. So the fluid will come into the scrotum, and if you squeeze the contents, it will go back also. It will go back slowly, not as easily as in a hydrocele, but definitely if the child lies supine for a while, then if the child sleeps and in the morning, this hydrocele will disappear and only will gradually develop during day. And also during examination, when you feel this, it's not a very tense hydrocele, and it will empty also. But then you will feel that what is emptying is fluid and not bowel or omentum or ovary. Okay, so differentiation between a hydrocele and a hernia from a therapeutic point of view is not very important, in the sense that how you treat it surgically is the same. You ligate the deep ring here in a hernia, whatever. But of course, the necessity to operate is greatly different. So inguinal hernia is, where it's a semi-urgent in a neonate and an infant. So you do it as soon as possible. But in an older child, it's a routine procedure. But a hydrocele is not, it doesn't need surgery until the child is at least about 2 years. Or sometimes you can wait as long as 4 or 5 years if it's not troublesome. So you got to differentiate whether it's a hydrocele or hernia. But even if you make the little error, the surgical treatment is the same. So because of that, it's not a major error. Okay, so a little bit of the epidemiology. So when any pediatric surgical, or for that matter pediatric topic, the epidemiology is the best way to start a conversation. So whether you write a short note on inguinal hernias, or in a viva, if you asked to describe inguinal hernias. So a very good starting point is to talk a little bit about the epidemiology, the incidence, whether it is male, female, preponderance, or whether if it is bilateral problem, whether one side is commoner than the other, and if there is a geographic variation, or if there is a racial variation. So if you know a little bit of that, you can always start your conversation or your essay with epidemiology, and then you will also gain a little bit of confidence as you go on. And if it is a viva, the examiner also will get a good impression of you. So always know a little bit about every little condition. So I used to have a little chart on my table in front of this thing. So all conditions, the little inguinal hernias. Okay, what is the incidence? What is whether the right side is common or not? So if you have a table of them for all conditions, like say tracheoesophageal fistula, Hirschsprung disease, or diaphragmatic, anything, if you have them all in one place, the incidence, whether if it is bilateral, which side is common, so that will be a useful one to have. As you go on, you can collect all these things, and then you will remember them as well, and that will be, you will know a lot about all those conditions, and you can always start a conversation confidently. Okay, so remember these little things. So inguinal hernia is one of the commonest problems in children. 3 to 5, probably I would say it's more closer to 3% in all children, but it is, all the, this variation is because if you take a cohort which has a lot of premature children, your incidence of hernia will go up, because the preterm babies or very low birth babies, as much as 30%. I think I lost the. Srina, I lost the slide. So how do you get the slideshow? Thank you. Okay, sorry about that. All right. Okay, so once again, to get back to that, so the preterm children or very low birth weight will have, the inguinal hernias are very common in them. So as many as a third of them might have it. So if your population has a lot of them, then you will have a higher incidence. But overall, it's about 3% of children will have a inguinal hernia present at some stage. Majority of them during infancy. And of course, the males consist of the predominantly affects males, and as much as 5 to 6 times commoner in males than females. And also now all these testicular problems, both undescended testes and inguinal hernias, are commoner on the right side. So twice as common on the right side, so 30% on the left side, 60% on the right side, and bilateral in about 10%. Okay, so remember that. And then the basic management of inguinal hernia. So if you see them as a GP or a pediatrician or any doctor, so if you see an inguinal hernia, so there is no place for conservative management. So there is no observation or watchful waiting. Doesn't apply for inguinal hernia, especially in children. Okay, so if you have so smaller the child, the more urgent is the problem as well. So when would you list them in your operating schedule? It depends on the age of the child. So younger the child, so in other words, a very low birth weight or that extreme premature child, you would do the operation before the child is discharged from the neonatal unit. So what we would normally tell is, we will tell the neonatologist, you tell us when the child is ready to go home. We will be operating him on that day, the day before discharge, and then we'll be sending home the next day. Okay, so younger the earlier. So 1 month old, maybe the next available list. 1 year old, as conveniently you don't have to really rush the parents, but we would tell them, okay, do it as early as possible, at your convenience. Okay, and also if the size of the hernia, if it is just a little hernia that's coming up and down in the groin that you see once a week or something like that, if the parents say, okay, it's very rare, but rarely they have noticed it, when the child is having a shower or whatever, then you don't have to really rush and do it. But if it is inguinal-scrotal hernia, so if the size of the hernia is big, inguinal-scrotal hernia, so all these, because why you do them earlier is that the incarceration of the testes or irreducibility of the testes, irreducibility of the contents of the hernia is higher in preterms. And also if there is incarceration, strangulation is also commoner in the preterm children. So that's why you would do them early. And also chance of getting incarceration is also much higher in the preterm. And also inguinal-scrotal hernia is more likely to get incarcerated, incarceration and then strangulation in the if it is big and if it is inguinal-scrotal. Okay, and and then the type of anesthesia, of course, it's we don't intubate them, so it is either face mask or laryngeal mask anesthesia, and it is combined with some local regional anesthesia, so either inguinal, either epigastric block, or a caudal anesthesia. Okay, and this is more for the the more pediatric surgical registrars. So whether you would explore now, I think this is probably not really necessary for you. And also the natural history. So if you operate on one side, you always tell the parents that there is a sometimes the hernias coexist in about 10%, but only one side becomes apparent initially, and then the other side can develop subsequently, or they might coexist also, but one side being bigger will make it more obvious, whereas the and then the other side becomes obvious once you operate on one side. It is not because you operate on one side, the other side appears, but so you have to warn them that if that other side does develop the same symptoms, for them to come back. Okay. And so you do not really explore the non-existent hernia. People used to do that, but then the autopsy findings of the older people have shown that a PPV exists, which is irrelevant clinically, or which will not subsequently develop into a hernia in about 30% or up to 30% of people will have it. So if you explore that, you will see there is a little PPV or a small hernia-like thing, which you will ligate and operate. And in the process, you might damage testicular vessels and cause some injury as well. But you're not going to gain anything because the majority of them would have been, the people would have died with it without any you ever knowing it. So there is no place for contralateral exploration in the majority. Sometimes people, will explore a preterm infant female where you can't damage there is nothing to be damaged on the contralateral side, even if you don't find a hernia, because there are no testicular vessels or anything to be damaged during surgery. So some people would routinely explore preterm infants preterm babies who are females, because they have a higher chance of having bilateral hernias, but so there is no real point. Okay. But the only drawback is that if you explore both sides in under 2 months, about 63% will have one anyway. But lots of them would never become hernias. So that's the reason why routine exploration of the contralateral side is not done anymore. So that's not really, yeah. So the sensible option is not to explore the opposite side routinely, but if there is a hernia that develops, then you operate it. Okay. So I think this is spoken and spoken. So again, incarceration. So about 10%, 10 to 15% of the pediatric hernias can become incarcerated at some point. So they are higher, commoner in certain categories like neonates or infants. And so because of that, that's the main reason why you operate them electively without waiting for it to get incarcerated. Okay. And incarceration is commoner in the female. So the female hernias, though rare, it's only about 20% or 15% of the hernias are in females, and the majority, 80-90% of the hernias are in males. But if you take girls, there is a higher chance, about 17% of the girls can get an incarcerated hernia compared to boys, who only about 12% will get incarceration. And the main reason is that the ovary, when it gets into the sac, majority of the female hernias are not the bowel, but the content is the ipsilateral ovary, and a little bit of the tubes also sometimes comes in. And once it gets into the hernia sac, it gets in, it finds it difficult, and there will be a little bit of edema, and then it gets stuck there. The danger of this getting incarcerated is that you can lose the ovary. So that's why female hernias also, particularly if they come with an incarcerated hernia, a female, that becomes even more emergency than in the boys one, because you can lose that ovary if you do not intervene early. Okay. So normally in a male, you would try to use taxis. Now, this is not a thing that you would use in an adult hernia, but in children, you can sedate the child, keep the little baby a bit buttocks up or a little head low, get the mother to hold the child horizontally with the buttocks up a little bit, and you apply gentle compression. And sometimes you can use a little cold pack also, not certainly ice cold, but cold pack. And then it'll help. Majority of the time it'll reduce. And then most people will operate the baby when the edema of the hernia sac goes down. That will be in about 24 to 48 hours. But it is not, The only thing is that these hernia sacs become very friable in the first 24 hours, so that it can tear when you repair it. If you repeat, so if the reduction is difficult, you can't use, you're unable to reduce it, but on table, so you under GA, sometimes you have to reduce the hernia, and people used to reduce it, wake him up from the anesthesia and then go and operate the next day or the day after. But if you are experienced enough and if you are gentle enough, you can do it in the same sitting, reduce it and then operate, but you have to be careful not to tear the hernia sac, which is a bit edematous and these things. So the two things, it can tear, and also you can damage testicular vessels in these small children. So you have to be careful, but you can do that. And there have been reports of minimal access techniques or laparoscopy for inguinal hernia repair. It is useful in bilateral cases and definitely in recurrent inguinal hernias in children. And also in the very small preterm babies, the chance of a testicular ischemia following injury to testicular vessels following standard procedure is high. So because of that, laparoscopic inguinal hernia repair is used selectively in very small babies, recurrent hernias, and rarely bilateral hernias. But the disadvantages are you need intubation. So it's a little longer procedure, and also you get into the peritoneal cavity, so there will be a little bit of ideas. You might have to do it. You can't do it probably sometimes in these small babies as a day procedure then, and because it's under it's an endotracheal intubation. You do it. You can't do it with a mask, and also the scars are on the abdominal wall. So where inguinal hernia, we do it on the skin crease. So the scar disappears if you side the incision properly. You will never see a scar in these children when they are bigger. But laparoscopic scar sometimes is visible on the abdominal wall, even though it's shorter, still will be more visible actually than the open inguinal hernia incision, which is about 1.5 centimeters. But these incisions are 5 millimeters, but they're sometimes more visible. So that's also a slight disadvantage. Okay, direct inguinal hernia, you don't even have to remember because it's so rare. Only about 1% of the hernias in children are direct. So you can practically forget about that. Femoral hernia also are commoner than what was thought to be. It's about 2%, but they're being picked up mostly because of the advent of laparoscopy. So there is a funny hernia in the groin, so you do a laparoscopy and then you can pick it up more easily than clinically. So a little bit about the management of hydrocele. There's a big part of conservative management or watchful waiting. You do not rush and operate the hydrocele. So certainly don't have to operate them before 2 years. So you can, these you do not have to refer immediately as general practitioners or pediatricians, and you can refer them even at 2 years unless they are huge, and when the patient starts walking, if it involves with the gait and if it is huge, then you can operate at 1 year, but you have to be very careful not to injure the spermatic vessels during mobilization of the PPV. Okay, and we'll get on to the undescended testing. So Rohan, shall we make the session open for the students to maybe ask questions?
We'll take some questions. Until students ask questions, Sanjay, I also have a question.
Yeah. So, but
it's not like he's very poor in pediatric surgery. But I have a little doubt. Now you said the difference between a hernia and a PPV.
Yes.
Is it the presence of is it the contents? Because you said
it is a yes. Yeah. So it is entirely depends on the content. So if the contents is the peritoneal fluid, which will get into the PPV, and then it will become, it's called a hydrocele. But if the contents is bowel, anything intra-abdominal, so predominantly bowel and omentum in the males, bowel or ovary. Ovary commonly in females, most of the time we see ovary, but sometimes the bowel can get in as well. but most of the incarcerated hernias will have the ovary. But yes, so in females, hernia is because it has contents, intestine, solid contents in it, but the liquid content, that is the normal peritoneal fluid, if it gets into the PPV, then it becomes a hydrocele. Yeah, so 100% because depending on the content. So the content also depends on the size of the deep ring. So if the PPV is very narrow and allows only fluid to get in, then it's a hydrocele. And then if it is big enough to allow bowel, so sometimes actually coexist also. Sometimes we see cyst at the cord, they present with the cyst at the cord, but when you, at the time of exploration, you see a big opening where a loop of bowel, so a little bubonocyte kind of thing, that little opening, then you have a narrow segment of the PPV, and then you have the cyst at the cord. So, but if you just, when you do the tie the T ring, that's the end of the problem. So, or the treatment is the same. Yeah.
And Sanjay, you also said that direct hernias are not.
Yeah, extremely rare. Yes, yes. Some very premature children, slightly commoner because they are, their medial wall of the, the Hasselblad triangle, or the medial part of the inguinal canal is very weak. The posterior wall, so they can slightly commoner, but it's about 1 or 2% of the hernias are direct hernias in children. So great majority are indirect. So if you want to guess on it, it's always better to say indirect inguinal hernia. Sorry, indirect inguinal. So PPV always goes lateral to the inferior epigastric artery, so they are indirect inguinal hernias. Yes.
Yeah. During surgery, Sanjay, what is the difference between in adults we do repair of the posterior wall and indirect?
That's right. Yeah.
Why don't we do the posterior wall repair in children?
That's right. Yeah. So the first reason is that there is no weakness of the posterior wall in these children. It is simply the persistence that processes vaginally. So when you repair it, that's it. But if it's been there, say if there is an inguinal hernia that's been there for very long, and if it's a huge inguinoscrotal hernia, then the deep ring may have been stretched so much that it looks as if it's very weak. So in that situation, we would narrow the deep, you close the inguinal, the deep ring with absorbable suture, like a herniatomy, and then narrow down the deep ring, so you leave, you like a little bassinet repair, you bring the thing. It's very rarely needed, if you do 100 hernias, maybe 1 or 2 will need that, especially in the preterm. But proper, like a proper bassinet repair kind of thing, where you would want to repair the medial part of the inguinal canal, is very, very rarely needed. Yeah, hardly ever, only about 1% of the babies will need it. Yeah. And so certainly we will never be using measures in them, because these children will be growing, and then if you use prosthetic material, then it will kind of limit the growth in that region, and then we'll have problems. So, and it's not needed. So recurrence of inguinal hernia is very rare in children. So after herniatomy, only about 1 or 2% will develop recurrences, and that too in very preterm babies. And also majority of it is due to a technical error. Sometimes, you're not, close the deep ring or ligate the persistent sac. So it is more, now adult, the recurrence is mostly due to patient factors, but in children, I think it's more due to surgical factors, recurrences. So herniatomy alone is enough. We will not be using measures, but very, very in the rare instance of direct inguinal hernia, we will be doing a little bassinet type of repair, where you bring the conjoint tendon down and stitch it to the inguinal ligament, and then that will sort the problem out. Yes. Yeah. So that is mainly because of the, there is no inherent weakness of the posterior wall of the inguinal canal. Yes.
Yeah. Just for highlight some of the key things that you said.
Yes.
For some of the students, probably to say it's a hernia, what is really important is the contents that you have inside.
That's right. Yeah.
If it is, if there is viscera inside the sac, you really consider it as hernia. Paediatric hernias, the treatment is surgery. There is no conservative management, and surgery is offered as early as possible.
Especially in the younger the child, the earlier the operation has to be done. Yes.
Surgery. And the surgery, compared to adults, there is no herniorrhaphy. It's
Oh,
hernia
yes.
come.
That's right. Yeah, herniotomy only. Yeah, yeah, exactly. Yes.
So I think cleared my doubt. So students, up to the students to ask questions.
Yeah, if there's anything, yes. There is nothing called a stupid question, only a stupid answer. So you can ask any amount of questions.
Sir?
Yeah.
So is there a specific reason why it's more common on right side rather than the left side?
Yes, so embryologically, people, these are all, hypotheses. So the test is naturally the right test is descends a little later than the left test is. So that's the observational finding. And people think that because of that, there is less chance for the right PPV to obliterate than the left side. So those are hypotheses. It will be difficult to kind of conclusively prove what is the reason. But yeah, so that's being put forward as the commonest reason of, people wonder, but it's simply, it has little time for closure when they are born than the left side. So that, and also that's the reason why right undescended test is slightly commoner than the left one again. Yes. So that, if somebody asks you, you can probably say that as the reason. And I don't think nobody will be able to, probably argue with you, but, that's observation and the possible explanation, I suppose.
Thank you, sir.
Okay, you're welcome. Anybody else? So,
hello,
lots
sir.
of, yeah.
Yes.
So is there risk of incarceration following the herniatomy, sir?
Yeah, so for you to get an incarceration following herniatomy, you will have to have a recurrence. So I think it's commoner in the adult, but in children, the recurrence itself is very rare, 1 or 2% will have it, whereas in adult it will be 10, in double-digit numbers, isn't it? So if you have a recurrence, yes, there is a chance of that getting incarcerated as well. So you can't delay it. So once you pick up the recurrence, you will got to operate on it, yes. But fortunately, the recurrence is rare, and also it is, if you improve your technique, the recurrences will be, less as well. So yeah, so you can't blame the patient on the recurrence, whereas, in adult, you can say you have been smoking or you've been coughing a lot, or, some other problem, maybe you got a prostate, so treat it, but not in children. So it's mostly the surgeon to be blamed for recurrence. Yeah.
Sir, is
So
there...
preterm babies, of course, have a higher chance of recurrence. So there is a little factor in children also. But yeah, preterm children with a large inguinal scrotal hernia, recurrence rates are commoner, yes. Yeah, so that not the blame, not the surgeon is not to be blamed there, but yeah. Okay, yeah, what do you want to?
Sir, is there a place for ultrasound scan during the diagnosis, sir?
Not if you are experienced enough to feel it, but majority of the patients, when they come to us, they bring in a ultrasound scan. So I think they are mostly referred by the pediatricians and the GPs. So if they are not, if you don't see them regularly, or if you don't feel the hernia, and so the most reliable, actually, sometimes we are also unable to demonstrate the hernia, but if you speak to, so history is very important in these patients. So if you talk to the patient, the mother usually, so this lump appears when the child is, usually it's common for the hernia to be visible when the baby is taking a shower or having a bath, because then the child is undressed, so you can see the groin. And also, if they put cold water on the body, the immediate reaction is you will kind of tighten yourself up, and then the abdominal pressure, intra-abdominal pressure will go up, and then the bowel contents, the contents of the hernia will get into the, it will come into the hernia sac. So because of that, it becomes visible at that time, or sometimes when they strain to pass stools, or during micturition, or sometimes at the end of the day when a child is, if he has been playing, and then when the mother changes clothes, then you see it. Yeah. So so the history, the description the mother gives, and also the site of the lump, just above and lateral to the pubic tubercle area, where you can feel the superficial inguinal ring. So that area, you will, they will say the lump appeared there, and if it comes during these, various maneuvers of raised intra-abdominal pressure, and then it disappears quickly. So that history is the most reliable thing or most valuable thing in making the diagnosis. And also sometimes you can demonstrate it, the baby, you can't ask these little babies to cough, but if they cries while being examined, or sometimes you can feel the open inguinal, superficial inguinal ring also when you feel it. And sometimes, of course, you might be able to feel the contents also. Then, of course, you can confirm it without any doubt. And so history plays a big role. And if there is a doubt, you can ask the parents to take a little, nowadays, everybody has video cameras on their phone. So you can ask them to record it or take a snap, and then that will help you diagnose it. So those are much more reliable than the ultrasound. But ultrasound, it's not harmful. So it's okay to do ultrasound, and then that will also help you confirm. But of course, the persistent PPV also, so the majority of the sonographers knows that, they should demonstrate bowel contents or ovary in the sac. So if that is possible, if it is there, then you can confirm this thing. But for a surgeon to ask for a ultrasound to confirm it is rare. But say if you are a primary caregiver or pediatrician, then that's okay to ask for the this thing, because if you're not sure enough, there is no harm in asking for the ultrasound there.
Thank you, sir.
Okay. Anything else? Any other questions? Any other questions that Rohan and them have set it up in the previous exams and that's not very clear for you? Have you? So all of you are final year medical students, is that right?
No, Sanjay, there are full range of students.
Okay.
Final year,
Yeah.
third year, fourth year.
All right.
These are final years.
Okay. And so you can ask any question, the questions that you have encountered about any of these, or even outside the topic today, if you need any clarifications there. Anything about children's surgery. So in that case, shall we get on to the undescended testes? Or?
Yeah. Yes, we move on to the next one.
Yes. Yeah. Okay. So this is a little diagram of the male and female genital development. So you can see the mesonephros, so that disappears, gets absorbed in the humans, and then the metanephros develops into the rete testes and testicular cords in the male, in the absence of Mullerian inhibiting substance. So this is all determined by the sex determining region of Y, so SRY gene in the Y chromosome. So if it is positive, the embryo becomes a male. But if so, a female is like a, in the absence of SRY, everything else becomes female. Okay, so when you have SRY, there is a Mullerian inhibiting substance being secreted, and that you get Sertoli cells that secrete MIS, and all the Mullerian structures gets inhibited or gets regressed. Okay, so mesonephric component regresses. The paramesonephric gets regressed. The mesonephric will persist. Okay, so you will have the mesonephric duct becoming the vas deferens and the rest. Okay, whereas in the females, the paramesonephric duct will form the fimbriae and the ovarian tubes or fallopian tubes and the rest. Okay, and so a descent of the testes, of course, is a little complicated thing. So you have the caudal genital ligament and the intra-abdominal part of the gubernaculum, and also extra-abdominal portion of the gubernaculum here, which is initially attached to the symphysis pubis. And then there is initially shortening of this upper part, which will bring the testicle towards the superficial inguinal ring. And then at that time, the gubernaculum also migrates into the bottom of the scrotum. And then again, the further contraction of that will result in the testis coming into the scrotum. Okay. So if there is a problem in any of these, you will end up with the rest of the testicle at some point above. And so the mechanism of testicular migration is multifactorial, or nobody really knows. So all these are little things that we found in studies. So differential body growth also helps. So the people think that the gubernaculum doesn't contract, but the gubernaculum will prevent the testis from going up, so that the child grows, the rest of the thing, so the testis remains there. So it is ends up in the near the superficial inguinal ring. Okay. And also when the abdominal pressure develops due to all these bubble loops returning from its physiological umbilical hernia that you have in early life, early fetal life, so that also contributes to pushing the testicle down and out. Because in certain conditions where there is no pressure, so if I don't know whether you heard of this condition called prune belly syndrome, where there is no abdominal wall musculature and the abdomen is so lax, and then there is no pressure inside the abdomen. So it is always, that's associated with bilateral undescended testis. So for that, to diagnose prune belly, also you have to have bilateral undescended testis. So, and also similarly, if you have a large omphalocele and all the bowel contents are outside, so there is less pressure in the abdomen, they have a higher incidence of undescended testis. And similarly, if there's a gastroschisis, I don't know whether you know that condition, it's a bit similar, where all the bowel loops lie outside, the rare condition in Sri Lanka, unfortunately. There is a higher incidence of that. Also, then there are certain hormonal factors. So if there is a lack of or deficiency of testosterone, and also deficiency of Mullerian inhibiting substance, and also maternal extrinsic estrogen. So if you have taken the pill or some estrogen supplement or whatever, and then there is a higher incidence of undescended testes in the progeny. And also people found that there is a abnormality, or sometimes abnormality in the development of the epididymis. Lots of these undescended testes, when we operate, we see that the epididymis doesn't look normal. So they what we call an uncoiled epididymis. In some of them, there is a hairpin epididymis. So a lot of abnormalities. Majority of especially the intra-abdominal testes, do not have a normal epididymis. So it can be a result of the testes being stuck there also. So it can maybe the result of undescended testes causing the epididymis to be abnormal, or whether the abnormality and the epididymis is a reflection of a defaulting or defective testicle is, of course, a doubtful thing. It's like the chick or the egg which came first, but so that's association that we see. Okay. And also gubernacular attachment. So now people feel that the gubernaculum is not only attached to the bottom of the scrotum, but it may be attached to other places. So in that case, you will have what you call ectopic testis. Ectopic testis is a much more rarer condition. Only about, say, if you see about 50 undescended testes, you will see 1 or 2 ectopic testes. But so ectopic testis is the difference between the undescended testes and ectopic testis is that the undescended testis is arrested in the normal, the descent of the testis. So it will be along the testicular arteries intra-abdominally. If you know the position of the testicular artery intra-abdominal, so it can be in any of that position. And then it may be in the deep ring, it may be in the inguinal canal, maybe near the superficial inguinal ring, or it may be in the upper scrotum. So any of that is called undescended testis. But if it is ectopic testis, then it has to be away from this test. It is not in the scrotum, but any other place like the perineum or abdominal wall or any other site. Okay. So the gubernacle attachment, if it is attached to a different place, then people think that these ectopic testes are because the gubernaculum is attached to an abnormal position. And also people have found that there are abnormalities in the genital branch of the genitofemoral nerve. So it's the neurotransmitter is the calcitonin gene-related peptide, CGRP, and there is a deficiency of that. So in these, it's found that this is low in the undescended testis, so people think that may be the cause. So I told you earlier that there is this relative position of the testicle. The people have found that if you calculate the distance, so if you do ultrasounds intrauterine babies, normal babies, if you calculate the distance between the bladder neck of these babies to the testis, the distance more or less remains the same. So it's the ovary actually which ascends more or less. So because of that, that's why people think that the testicular descent is a manifestation, or it's a false appearance of descent, because the rest of the things goes up. Okay, so that's a little new hypothesis. So I mean, you don't have to confuse it. So and then soon after birth or just before birth, it goes the other way. So the last little bit from the bottom, the near the superficial ring into the scrotum it's going in the opposite direction. So unlike the ovary, so that's the only descent that takes place. Okay, rest of the descent from the near the kidneys to the superficial ring, people now argue that it is really the ascent of the other organs or differential body growth. Anyway, it's a bit confusing. I think not really worth going into detail. And also the epidemiology, I told you that it's one of the commonest urological anomalies. So if you take all children at birth, if you examine them and feel about 4 to 5% will have undescended testes. But I think some of these are, false identification, or some of these are retractile testes also. I feel that that's why it's a bit high like that. And of course, when they are 6 months, it drops to 1%. So only 1% of babies when they are 6 months will have undescended testes, but about 4 to 5%, as many as 4% will have undescended testes at birth. So you certainly don't operate on them until they are 6 months. But there is no point waiting beyond 6 months because they never descend after that. Okay. And of course, the preterm babies, even as many as 30%, with the natural history of the descent, that the majority of the scrotal descent takes place just before birth. So if a baby is about 10, say 32 weeks or maybe 28 weeks, then they are 100% undescended, because the testicular descent takes place in the last part of the last trimester, latter part. Yeah. Okay, so at 3 months or at 6 months, only about 1%. At 3 months, maybe 1.5% of them are undescended. Okay, so the effect of cryptorchidism. So you have the primordial germ cells in utero, and then that becomes neonatal gonocytes. Okay, so if you have an increase in the neonatal gonocytes, they become malignant. Okay, so that's the reason why you have this high incidence of malignancy in undescended testes, and type. Then they become at 3 months, it becomes type A spermatogonia. Okay, so then so that's why there is a certain amount of failure in processing of these gonocytes. Eventually become spermatocytes and sperm. So if there is damage, so then they become mature into type A spermatogonia when the child is 1 to 3 years, and then type B spermatogonia 3 to 4 years. So you do not operate them until about 6 months, but if you delay it beyond 6 months, then there is further reduction of this type A spermatogonia, leading to subfertility. There is a certain amount of inevitable reduction in the sperm counts, even if you operate at 6 months. But that will be much less when you compare to somebody who has had their orchidopexy beyond 1 year. Okay, so that's the, so because when we were students, we learned that the orchidopexy has to be done at 2 years, and lots of the pediatricians still wait till 2 years. I don't know, maybe because they have learned the wrong information, so they have not been updated. So remember that orchidopexy, the optimal timing of orchidopexy is between 6 months and 1 year. So if it is an intra-abdominal testis, we would like to do them when they are maybe 6-7 months. But if it is, outside the superficial ring, then, 9 months is okay. But definitely before 1 year. Okay, so there is no place for waiting beyond 1 year. And also people think that if you do them at 6 months, or now I think there are studies in US where it's done a little bit earlier, maybe 5 months, that they feel that the incidence of malignancy in the undescended testes also can be reduced by doing them early, say 5 to 6 months, because of this, then there is less effect on the gonocytes, and the chance of malignancy. Now, normal, the teaching or the normal thinking is that even though you bring the testicle down, there is no reduction in the incidence of malignancy, but it will make it more obvious. So if a testis is in the scrotum, it will be easier to palpate. And if there is a change in the morphology or the contents of the scrotum, you can palpate it. Self-examination is easy, but if it is intra-abdominal, you cannot feel it at all until it becomes huge and becomes a massive mass. So bringing the testis to the scrotum helps in early identification of testicular cancer, but the operation did not reduce the incidence of the malignant transformation that subsequently take place when they are around puberty earlier. If you do the orchidopexy after 2 years, certainly doesn't change the incidence. But now people have, found out a little bit of a reduction in the incidence of malignancy in the undescended testes if you bring them down a little earlier in life. So that's one of the reasons why you would do them, apart from the added benefit of better fertility. Maybe a slight reduction in the malignancy, but certainly you have to still be very cautious, and you have to inform the patients and the parents to be on the lookout. These malignancies don't develop when they are little babies, but usually they develop when they are around their puberty. The second malignancy. The malignancy in the undescended testes is about 10 times commoner than in the general population. But still very rare. You don't have to really scare the parents about the malignancy, because majority, only maybe less than around 1% of the undescended testes will eventually become malignant, or maybe a little bit more. But it's still rare. 99% will not have malignancy. Okay. So fertility. So if the orchidopexy is before 2 years, 87% of fertility. But if it is done around 6 months, about 94% will have normal sperm morphology, sperm counts, and also fathering. The ultimate test is to father a child. So just the sperm counts itself may not be a good reflection of the fertility of that particular testis. But so even studies that have followed up these children until they are sexually active and then eventually have families. So they have found out that if you do the surgery around between 6 and 9 months, the rates are much better than if you do it after 1 year. And certainly, definitely, there is absolutely no place for doing it after 1 year. Okay. And if you do it around puberty, it's very low, 14% only. So the current practice is to do it around 6 months, but then there are a few centers, especially in the North America, which even do it between 3 and 6 months also. that's a little bit of the other extreme. But I think only time will tell. I mean, so maybe in 10 years, when you become pediatric surgeons, you might tell them, okay, when we were students, we were told to do it between 6 and 9 months. Now we do it at 3 to 6 months. So only time will tell. But we'll see. Yeah. And the risk of malignancy varies widely. The certain studies say it's about 5%, and when there are studies which says about 30 times higher. So the common number that you got to remember is it's about 10 times commoner in the undescended testis than the normal population. Okay, and so the risk has been shown to be slightly less if you do the orchidopexy early. And also the position, so intra-abdominal testes have a higher chance of malignancy. So in so much so that it's about 5% of them can become malignant subsequently, whereas extra-abdominal, it's about 1%. And also this ascending testis. So that is, where the clinician has recorded that, okay, now at birth or soon after, or at some point during the early life, so maybe within the first few months, somebody has noticed, okay, this recorded that this patient has both testes in the scrotum, and then in a subsequent examination, one side is absent. So that is called ascending testis. You cannot rely the parents entirely to diagnosis. So there has to be some clinical documentation that the testis has been, they are in the scrotum. So you rely on that initial examiner's finding whether he felt the proper testis or not is a bit of a question. But anyway, so ascendant testis is a testis that has been in the scrotum at some point in life. Now, when they come back, he is not there. So rare, but it's definitely described. So that is common in a non-operated child, and also sometimes can happen in a child who has had an orchidopexy, or sometimes now in the Western Europe, there is a tendency for these undescended testes to be hormonally manipulated or treated hormonally with HCG or LHRH or these GnRH analogs or HCG or both. And in those patients also, they found that it comes down, but once you stop the treatment, it goes back. Okay, so ascending testis could be any of those three. And of course, it's easy to understand in a orchidopexied child, how a testis can go up is that you mobilize these testicular vessels maximally. Now, normally, if you can remember your anatomy, or if you have done some dissections, you would see that the testicular vessels is not a straight line from the aorta to the groin. So it is a little bit curvy. So there is always some play, and it will not pull the testis up even if you stretch in the abdomen. So when there is differential body growth, so if the body grows faster than the testicular vessel, so and if the testicular vessel is like a straight line after testicular, so we use that to bring this testicle down, mobilize the vessel, so that eventually it becomes a real straight line, and your scrotum is, testicle is there, and this testicular artery can pull it up or prevent it from, so it will keep the testicle in the same position, and if the body grows, the rest of the body, then the testicle will get pulled up into the groin from the scrotum. So we found that if you get the parents to do a little bit of kind of massaging, you can call it, or little pull on the testicle when they change nappies soon after surgery, it will stimulate, in these small children, if you stimulate, put some tension on any structure, whether it's the upper pouch or the esophagus, tracheal fistula, or sometimes you may have seen, mothers, molding the various parts of their body, noses and fingers and things like that. So any stimulation, any pull on a structure, particularly in the infancy or neonatal period, will make it develop, grow in that direction. So if you, after the orchidopexy, we will tell them to, pull a little bit of the thing or gently massage it when they change nappies. That will help to kind of ease the tension on the artery, because then that stimulus will grow it a little bit further. Okay, so ascending testis is because of that, mostly because of the tension. And also the undescended testes, apart from subfertility and malignancy, there is an increased chance of torsion in that testicle because the testis is not fixed like in the normal position in the scrotum. Quite a high percentage of the undescended testes, if it goes on beyond 6 months, especially when they are the active, physically active, can become torted. So torsion is much higher if you don't do orchidopexy in time. And also they are more prone to injury. You know, the fact that the testicle is hanging in the scrotum loosely will prevent it from getting squashed between, you know, say if you just imagine you leaning onto the table or accidentally bumping onto the edge of the table, and if your testicle is near the symphysis pubis or pubic tubercle, it will get squashed in between. So more prone to injury. Or if your colleague will, you know, kick you in the groin, then even in the normal position it can, but it's much more prone to injury if it is undescended. Okay, and also. Of course, there is a psychological effect of an empty scrotum, so it's big issue in children. So much so that if there is absent testes on one side, we can use a prosthesis when the child is a little bigger and more aware of his body habitus. And also, so there is no, you know, the best form of investigation is the proper clinical examination of the child. So you confirm whether the testis is in the scrotum. So, you know, these parents will come to you with an empty scrotum. So the first thing is to, you know, after you chat to them, you know, have they noticed it at any point in time? So, because in sometimes the retractile testis, the parents would have noticed the normal testis after a warm bath or during some point of life, and then it goes up. So the parents themselves will be able to tell you, give you some history to differentiate the two. Undescended testis will never be there at certain point of the day and, you know, some time or the other. But the retractile testis will certainly be in the scrotum normally. So, so that's the important part in the history. And so once you confirm that there is undescended testis and it is not a retractile testis, so anybody knows how to differentiate retractile testis from undescended testis? Any volunteers? Anyone has heard about the retractile testis? I'm sure you do.
So
Yeah.
retractile testis can be manipulated or milked down into the scrotum without tension.
Yeah, very good. Yeah.
While you can't do it with undescended testis.
Also, now once you pull it down, then what happens if you let go? What should it do? The retractile testis, so you know, milk it down or you squeeze it down into the bottom of the scrotum, and so it comes and, you know, you can touch the bottom of the scrotum easily. And then, so if you let go, a retractile testis will do what? Will it spring back into its original position in the groin or somewhere, or it will remain in the scrotum? Yeah, it should remain in the scrotum at least for a short while. Once you let go, immediately after it won't go up. You know, if you accidentally stimulate the cremasteric, so if you touch or if you scare the child a little bit, then it will go up again because the cremasteric reflex will pull it up. But as soon as you pull it down, it comes down, and you will feel that the tension on the thing kind of suddenly relax. You know, the cremaster relaxes when you pull it down, and when you let go, it just remains in the bottom of the scrotum without any help. Okay, so that is also part of the, you know, to confirm the test retractile testis, you will have to be able to pull it down and pull it down right to the bottom of the scrotum. And also when you let go, it will remain there for at least a few seconds or minutes. Okay, at least. Possibly at the end of the examination, when you dress him up, it will still be in the bottom of the scrotum, unless you stimulate the cremasteric reflex by touching his thigh or, like, you know, stimulating the groin area. Okay, so the test at the end of the examination, the scrotum will be occupied by both testicles, and then you can call it the retractile testis. But undescended testis, particularly one which is suprascrotal or near the superficial inguinal ring, even if you pull it down with a lot of effort into the scrotum, it is unlikely to touch the bottom. And also, even if it does, and if you let it go, it just springs back immediately. You will feel that also, that, that give way of the cremasteric muscle that is, causing the retractile testis. You will feel that it is, there is no kind of physical, cord-like thing pulling it up, but it just relaxes and comes into the scrotum. And then it remains there for at least some time before it goes up again, because the cremaster contracts. But the testicular, undescended testicle will be like you're putting a really tight cord, and then it just springs back into the original position as soon as you let it go. Okay, so that's the difference. Very important differentiate. Otherwise, all these studies will get tainted by putting retractile testes into the undescended population, because they are completely different. So retractile testes, we consider it a normal kind of a physiological thing in children, so we do not treat it at all. And then there are certain, the Western Europe countries where they give hormones to these children and make mess of it. Yeah, so certainly do not give hormones of HCG, and they have a lot of side effects, and some of it will not be known until you use it widely in these small children. And common sense will tell you that if you use hormones in children unnecessarily, it's going to be very detrimental. So so obviously some of these changes that are obvious are, they will look like little old boys. These little children will be almost unrecognizable when you give androgens to them. Very rarely we do use them in these hyperspadias patients. So we have seen, like, it sometimes is a bit shocking to us also. The little baby that came to us 3 months before these injections suddenly looked like a big fellow. And they can, become sexually kind of active also a little bit. They might look at the females a little bit differently than when they are, not like little babies. So always very take seriously when you give androgens to these babies for any reason. And also they can, if you give it for longer periods and at a higher concentration, this HCG can cause a premature fusion of epiphysis and permanent short stature in these babies. But most of the other appearance of these sexual things disappear, the enlargement of the penis, the, sometimes erections in these little babies will disappear once you stop the treatment. But if you, some of the, the bone fusion of epiphysis and things will be irreversible. So there is no place of hormonal treatment in the retractile testis, definitely. And even in the undescended, I'll come back to it later on. Okay, so what is the role of imaging in impalpable testes? So now, the most important thing after your history in the undescended testes is the examination. So you have to be good at examining these patients. So only thing is that if you encounter them very rarely, like in a general practice or sometimes even pediatrician, so you cannot become expert in feeding it. But if you are a pediatric surgeon or surgeon, then you should be able to feel the normal testicle and easily differentiate it from an inguinal lymph node or anything else, or inguinal hernia for that matter. So the testicle, if you are able to feel the testicle in the groin or upper scrotum, then it becomes what is called palpable undescended testis. So it's a very important term. So in the undescended testis, there are only two types. One, as far as management goes, so one is a palpable undescended testis, and the other is an impalpable undescended testis. Okay, so about 20% of the undescended testis are impalpable to an experienced examiner. Okay, and the 80% will be palpable. Okay, so the palpable testis, there is absolutely no need of any further investigation, including blood investigation. So you can fix it for orchidopexy. There is no other investigation like ultrasound in a undescended testis if you can feel the testis. So 80% of the babies will be like that. But if there is an impalpable testis, then what would you do? A majority of the patients, even palpable ones, will come to us, waving a report of ultrasound examination, which very rarely we look at. But even in the impalpable undescended testis, the ultrasound will not add to your management, because suppose the ultrasound says the testis is not there, you cannot just send them off home. Okay, there is no testis, there's nothing we can do. You can't tell that, because the great majority of the intra-abdominal testes will not be visible to the ultrasound, not be visible in a normal ultrasound. Okay, so you cannot rule out the intra-abdominal testes by just because the testis is not there. So if the ultrasound says there is an intra-abdominal testis, so you have to go and do what you call a laparoscopic orchidopexy anyway. Okay, so if the answer to, if investigation will have, either positive or negative, if both positive and negative will lead you to the same intervention, that investigation becomes redundant, isn't it? So even if you do ultrasound and it says, okay, testis is there intra-abdominally, you do a laparoscopy and see, do orchidopexy, hopefully. And even if the ultrasound says no, still you have to put the laparoscope in and confirm whether the testicle is there or not. So you end up doing the laparoscopy anyway. So both findings of the ultrasound will lead you to the same intervention. So that becomes redundant, isn't it? So any investigation, so that's the good way of finding out whether a certain investigation. So it has to change your management strategy. So ultrasound has absolutely no place in undescended testis because of that reason. So impalpable undescended testis, then we'll go on to have a laparoscopy. And if the testicle is there, then you can do a laparoscopic orchidopexy, whether it's a single stage procedure or a Fowler-Stevens stage procedure, depends on where the testicle is and how easily it can be mobilized and brought down. But so the next step in the undescended testis, impalpable one, is the laparoscopy. You schedule them for a laparoscopic orchidopexy as early as possible, or between 6 and a month. Okay, so ultrasound has almost no place in undescended testis, both palpable and impalpable. Okay, and then there are various reports of MRI, CT scans being done, but has very little value because whatever you find. So if a particular examination can confidently say 100% patients that the testis is absent in this patient intra-abdominally, so that will be a valuable investigation. So then you can avoid the unnecessary, because these 20% impalpable testis, about 40% has absent testis. So that will be either some kind of a vascular insult intra-abdominal. Majority of them may be intra-abdominal torsion of a intrauterine, or soon after birth, and in the first 6 months, a torsion or some other vascular insult like embolus or something. So they will have absent testes, or you will see them blind ending valves and blind ending testicular vessels in them. Then you conclude that, okay, this patient has an absent ipsilateral testis. So there is nothing that you can do surgically to bring that down, but later on you might be able to put a what you call a prosthesis, testicular prosthesis, to make it look similar and to, cosmetically, to make it more cosmetic. And then, so if those patients can be identified before the laparoscopy from whatever investigation, then that will be a very useful test. But there is no test to conclusively or 100% tell that there is no test, because the problem of not identifying intra-abdominal testis is that they can come to you when they are around puberty with a malignancy, and then they can sue you and saying that so you didn't pick this up, and so there will be problems of litigation later on, or if not litigation, just your conscience wouldn't be clear. You will not be able to sleep well because you have harmed somebody. So because of that, it is important that up until now we have no test to conclusively prove that there is no intra-abdominal testis that will so that we don't have to do laparoscopy. So I said around 40-45% of them will have absent testis. These 20 impalpable testis, 40% will be absent testis. Another 20%, about another 30% will have an intra-abdominal testis that you can do an orchidopexy. And another about 20%, you will see that the testicular vessels and the vas difference will go out of the abdomen through the closed inguinal ring or open inguinal ring. So why have they become impalpable? Because the testicle has either become very, very atrophic and like a little nubbin or like a little nodule in the inguinal canal, or sometimes in the scrotum also. In some of these impalpable testes, you will feel that there is a tiny little nodule, but it doesn't feel like a testis, so you do not know whether it's intra-abdominal or not. So about 20% of the impalpable testes are not that they have not come down, but they have come down, but has undergone atrophy, commonly due to a undetected torsion. So that also may be antenatal or postnatal. Okay, so postnatal majority, when they are small babies, they might be screaming because of a torsion, but parents think, he's hungry, and then he might just, not pick it up, so that, they only pick it up when the testicle disappears. Okay, so out of the intra-abdominal testes, only about a third patients eventually end up with the test orchidopexy, because about a third or a little over third will have absent testes, and which is intra-abdominal, and another about 20% will have vas and vessels leaving the deep ring, but the testis is atrophied or absent outside the deep ring, or so in the canal or in the scrotum itself. Okay. Okay. So, and this controversial topic of hormonal treatment of undescended testes, you can more or less forget about it from a Sri Lankan context. We do not use it. And it's at best only about 10 to 15% respond to it. And people feel that even out of that 15-20% of the success rate, majority are wrongly diagnosed retractile testes that become, that comes down into the scrotum with the hormonal treatment, and not true undescended testes. Okay, so even at best, and sometimes when you stop the hormonal treatment, it goes back like what you call ascending testes. So there is nobody with the proper sense in mind will use the hormones to bring the testicles down. I'm not saying that because I'm a surgeon and then it's going to hit my, I'd be jobless if all these are not there. But there is no proof to say that it is of any benefit to the patients. Yes. Okay. So the role of surgery or the is to mobilize the testicular vessels and sometimes a little bit of the vas, because usually there is enough length in the vas, so you don't have to really mobilize it. It's really the testicular vessels that you got to mobilize, straighten them, and then and also one of the factors that prevent this from coming down is that almost 99% of these undescended testes will have inguinal hernia associated, or you can call it a PPV, but in majority of the case, it's a very wide PPV, so it's a hernia, which will actually, so once you separate the hernial sac for the processus vaginalis, and then in an open procedure, you will usually ligate the sac also. And then there is suddenly the testicle gets released, and you can bring it down easily to the scrotum. So majority of the palpable testicles, you can fairly bring the testicles down to the scrotum, so that they become almost inapparent. When you look at them 1 year later, they look as if nothing has happened here. Okay, so and yeah, so the impalpable testes, this is more for the surgical trainees. I don't think this is going to be of use for you. And also, again, the length of vas and the vessels. So what you do, intra-abdominally. So some of you who are interested in this, some who have a keen interest in surgery, maybe wanting to be surgeons in the future, they can come to our clinics, and maybe the wards, you'll be able to come on Fridays to my ward, and you'll be able to see some of these procedures and, do it. So those who are keen to learn a little bit more on this can do so at this thing. And I made some other, yeah, so now again, you can ask questions or discuss it. You can add some things that that I have missed or whatever. Anybody?
Sanjay?
Yeah.
Sumundu here.
Sumundu, all right.
I'm very sorry, sir. I joined very late.
Yeah.
Thank you very much. for sort of helping our students.
Yeah,
One
no
thing, I don't know whether you discussed, I joined sort of little late. Now, you said sort of retractile testis and undescended testis. Is the development of the scrotal Ruge pattern will give us a
when
clue?
you initial examination, yes, especially the intra-abdominal testis will have a hyperplastic scrotum. Yeah, so in the physical examination, so you will also, you know, notice that the scrotum is well developed or normally developed in the retractile testis, whereas the undescended testis, especially if the testis is really up, not in the upper scrotum or superficial inguinal ring area, the scrotum will be atrophic, but definitely not there in the retractile testis. They will be not looking normal.
Well developed.
Yes, yeah.
I hope you discussed about the hernia as well.
Yes, yeah. So
Okay,
we discussed in great detail about the inguinal hernias, different types, you know, all the presentation, everything. And then we discussed about the hydrocele and the normal development of the testicle, the normal descent, and then the undescended testes, and a little bit about the ectopic testes. And so we can even discuss a little bit about the acute scrotum if now, what time is it now?
It's almost 11 o'clock.
Oh, really? Then I think it's the time to stay.
And Sanjay, sort of, we can send few students.
Yeah, on Fridays then.
On Fridays, yes.
Okay, yeah. So Friday morning, we will meet up.
Where should they come?
Ward 10. Yeah, so come to Ward 10.
Ward 10.
Yeah, LRH. And so there will be groups of about 10 people.
We can send around between 6 to 10. Yeah.
That's wonderful. Yeah. So yeah. So 6 to 10, or you know, anything up to about 10, 12 should be okay. And then they can come around 8 o'clock. And then they can meet myself, and then I have 2 senior registrars as well. So we will take you, you know, through the common pediatric surgical problems, and then whoever who is in the ward, we can show you some of these things also. But wards, we generally keep them fairly less crowded these days. So, you know, there will be fewer patients, or there will not be patients hanging around in wards free because of the COVID situation. But we will be able to at least show you photographs and demonstrate some of these things. And my clinic is on Tuesdays. So maybe about 5-6 people can come on Tuesdays if they want to see these groin hernias, undescended testicles, all these routine pediatric surgery, you know, hyperspadias.
That is in the morning.
Tuesday morning, room 28, outpatients LRH, and between 8 and 12. So they'll be starting, you know, I'll be going there after a ward round. So they can even come to Ward 10, you know, join a quick ward
round and sort of go to the clinic.
Yeah, they can go directly to the clinic at about 8 o'clock and then look at these patients and then maybe take brief histories and be ready also. Yeah.
Thank you, Sanjay. Thank you very much.
You're welcome. You're welcome.
For helping us. And
yeah. So
Rohan is there.
Yeah.
Rohan.
Thank you, Sanjay.
Yeah, you're welcome. Yeah, we can. So if you have any further things like neonatal, say, you know, cholestatic jaundice, the common topics, pediatric surgical interest that interest the students, we can maybe organize another similar one maybe sometime later also, you know, depending on the student's requirement and your requirement as well. Okay.
Okay, Sanjay.
All right. Okay. Thanks. Thank you.